Thank you very much, Jamshed and Taiba, to give me this opportunity to speak today. And I have more friends probably in Pakistan than in India itself. And in this relay race, I'm running after two Doyens, and both my close friends, Anand and Martin. I've been to their institutions, they've been to my institution. I mean, at least Anand has been to my institution. And I have been to Sick Kids, I've been to KK. And I actually regret that I couldn't make it to Karachi. Personally, I would have loved to come. So with this, I'll start my talk. Just a second, please. Can you see my slides, please? Hello? Can you see my slides?
Yes,
Somebody?
Yes, we can see.
Okay, so PUE, we know the intervention. This is an algorithm kind of made what we do when the patient comes to us, usually in urosapsis, in neonatal oral infancy, and then how we go about it. And we all know that I call it EVI or PEVI, which is primary endoscopic valve incision, but others use all kind of other words, valve ablation, valve perforation, etc. There is a role of supravesical diversion as PCN or even ureteroscopy, and also in some cases where EVI is not possible, vesicostomy, and then we have this patient where at least the urethral plumbing is completed, and then we need to know how to go ahead after that. Even intraoperatively, I've seen surgeons putting the suprapubic pressure to see how good is the urine stream, and this is the card that used to be in the OPD earlier. And we show it to the parents and say, okay, tell me how far the stream goes, and then from there you will kind of have an idea whether this patient is micturating well, whether the valves are valves have been well taken care of or not. But now we have some objective ways of doing that to know the adequacy of EVI. We can also find urethral ratio and post-EVI VCUG. Of course, we still will do a chest cystoscopy, but this ratio of posterior urethra and anterior urethra, if we take out, and initially the values could be anywhere between 7 to 10. I even have had a patient where the value was running into 100. But post EVI, then we do a VCUG, we see that the ratios have improved. And in that also, the concept which has not yet been published anywhere in the world is that if you would watch different films of VCUG, you will realize that at the height of micturation, the urethral ratio improves much better than when the micturation just goes to finish. So we should take the film which has got the best urethral ratio as our guide to whether know that the EVI has been adequate or not. Or you could do uroflowmetry. Uroflowmetry, this is uroflowmetry done for a child where initial uroflowmetry shows obstructive pattern, but the same patient has had an EVI and uroflowmetry is perfect now. Diversion and undiversions, yes, there is a role of diversion and undiversions, a role of diversion in the patient of posterior valves. We know that whether if we don't have the scopes, we don't have the expertise, the child is very, very sick, we still go ahead and do diversions, Bloxham's vesicostomy, which became very, very popular in late 90s, eventually was thrown into the bin in another 10 years or so. Supravesical diversion as PCN or ureteroscopy is known. We have been doing the upper loop ureteroscopies or sober ureteroscopies in many cases. In last 10-15 years, we have started doing refluxing lower loop ureteroscopies also. And nephrostomies, I've already said that some institutions believe in putting TCS to know whether this kidneys are going to work or not. But this one thing which is very important is that not only the quantity but the quality of life is also important, and these patients need to go to school like any other child. So we must undivert them usually before 3 years of age when they're going to go to school. And if we have not done the EVI before, then while we're doing the undiversion, EVI should also be done concomitantly. But as we come into the 21st century, there were not many articles which were written against vesicostomy. Complications include stoma-stenosis, stomach prolapse, very strong ruptures, excoriation. But more importantly, rapid filling cystometry shows the primary EVI is associated with better bladder function outcome than the patients which are treated with vesicostomy and urinary EVI. And vesicostomy increases the need of bladder augmentation. In my early days, when I was being trained about 3 decades back, they used to just do adequate plumbing. They didn't even have a cystoscope in that department. There was something like a crochet, which later Mona Bram from Kochi gave the name of Mons Valvoto. And once that Ghocha, some people from Pakistan will be able to understand, was done, the patient was left alone. But the million-dollar question is, million-dollar question is whether that is sufficient. And these are the slides from Dr. Gharpure. These 2 slides are very, very important. That management of posterior urethral valves is like entering have you seen this naked ladder? So we treat one patient, something is done, and some other complication occurs, and he has one UTI, and suddenly his curtains rise. And then suddenly we realize the patient needs a transplant. So this patient needs to be kept under close surveillance and followed. That's why it becomes very, very, very important. So if a patient comes whose primary EVI has been done and the patient comes to OPD, then my resident has to show me all what is written in this slide. He used to mention the somatic growth, BP, urine dipstick, BU, serum creatinine, serum electrolytes, urine osmolality. I know many of us have forgotten about it. We don't talk about specific gravity of the urine, etc. But that's also very, very important, where we know that the kidneys are close to, getting knocked out or they're not too good. AVG, an ultrasonography, MCUG, the last one at least which was done, and then isotope renography, widening diary, a flow rate of uroflowmetry has been done, and video urodynamics, and a formal estimation of GFR. If we do not have the entire gamut of these investigations, then our follow-up is incomplete, and we are going to definitely miss something out on this patient. So what are the issues that haunt PUE subjects in the follow-ups? They are renal parenchymal dysplasia, renal dysfunction, renal tubular function, hydroureteronephrosis, vesicoureteronephrosis, reflux, vesical dysfunction, and most importantly, wall bladder. So we should pick up early and also treat them so as this patient do not go into ESRD and will not need renal transplant. That's our goal of follow-up and further management of PUE patients. The renal parenchymal dysplasia, that could be because of congenital effect of the tissue development itself. The etiology is high pelvic pressure during nephrogenesis and family embryonic abnormality from abnormal position of urethral birth, and severity will determine the ultimate renal function. So dysplasia is a very, very important factor. Progressive renal deterioration may occur because of UTI, because of hypertension, or because of progressive glomerulonephrosis from hyperfiltration, or if there is an obstruction. If while doing a PVI, you have done a urethral damage, then that's going to be a double whammy. And at times, the bladder neck hypertrophy, which is the obstructing again, if not taken care of, could create problems. So end-stage renal disease in these patients could occur in as many as 25 to 40% of patients. 1/3 would have soon after the birth, and 2/3 will have during late teenage. And these patients then need to be picked up and helped. Deterioration of renal tubular function, that happens in 50% of these patients, and they will have impairment of concentration ability, so they'll have very high urine volumes regardless of fluid intake or state of hydration. This will lead to eventually electrolyte imbalance and urethral dilatation and high resting vesical pressures. Hydroureteronephrosis, that happens because of
that cause coordination.
Can somebody unmute that? Hydroureteronephrosis, that also is commonly seen in these patients. So if it does not reduce in time, we should think of the situation when we are having high intravenous pressure, or there may be urethral muscle weakness, or even ureterocycle junction obstruction. VUR. VUR seen in 50% of the patients, 30% will have bilateral, 20% will have VURD. So VURD is where the brunt is taken by one kidney only. If VUR persists, ensure that there is no bladder outlet obstruction or bladder dysfunction. In infants, consider doing lower loop ureteroscopy. The bad ureter can be brought out in the just above the bladder in the suprapubic region, from where it will be refluxing into say the kidney. So natural progression of bladder. I mean, what we were missing say about 20 years back was that we used to take care of the urethra, but we did not do bladder therapy too well. But now we know that these patients could have reduced hypercontractibility, or they could have hypocontractibility. In fact, when you do a PEVI, then there are three phases in which bladder initially tries to kind of improve. It is at a compensated phase for a while, and then eventually, whether under the anticholinergic effect or otherwise, because of it will decompensate and this bladder will fail. So valve bladder syndrome, first described by Hormondal, and then Profitol has done a lot of work on it. Polyuria, as I have already discussed, insensitivity to bladder filling, failure to recognize the full bladder, and post-void residuals. There are three patterns of residual volumes: true residual, pseudo-residual, and pseudo-residual. So these are the ones which always keep the bladder full and then eventually gets into trouble. So putting it very, very simply, valve bladder syndrome would be seen in as many as 30 to 75% of patients in many series. So there is a decreased detrusor contractibility. So the detrusor is not really able to evacuate the urine well from the bladder, and also the bladder compliance is kind of decreasing. So whatever little urine that comes into the bladder will raise the bladder pressure. So TVRV is increasing, maximum bladder capacity is increasing, but the compliance is going down. So with that, quantity of life as well as quality of life goes down. The deterioration of upper urinary tract occurs, so that will kill the patient unless you take care of the kidneys and do renal transplant if required. And these patients will also have incontinence, which will make them socially unacceptable. They will not be able to go to their schools, colleges, etc. So it's very important to take care of this entity. This is very important. In last 10-15 years, even in developing countries like ours, we are talking about UDS, and more institutions are wanting to have a UDS machine in their department. But mind that the UDS are invasive and non-invasive. We are talking about invasive UDS when we are talking about those UDS machines. And one more thing I must tell you is that UDS is not equal to cystometry that we do on the invasive UDS machine. UDS is far more than that, and if we will talk about taking care and doing follow-up of the patient, the non-invasive, the most important thing is to do a bladder diary. One must note how many times the patient passes urine and what is the volume of the urine that the patient passes every now and then. Bladder function assessment can be done by urinary history, uroflowmetry, EMG may be done. Even that is not that invasive. You're not catheterizing the bladder at least. Observation of the child's posture during maturation, post-maturation dribbling, and TVR assessment using ultrasound. With that, TVRVs are high, you know you need to intervene. So non-invasive UDS are as effective as invasive UDS in the management of PUB patients. So if you do not have the UDS machine, no worries. If you will follow the things that is included in the list above, in non-invasive, it will work as well. So timing of UDS, even if you have a UDS machine, people are not very clear how often you should do the UDS machine, because these patients are on anticholinergic drugs, and you often need to kind of change the dosing as the bladder is kind of improving. The literature doesn't very clearly define how many times you should do UDS, but I again insist that you should insist on non-invasive rather than The invasive UDS, non-invasive UDS can definitely be done annually. Invasive UDS can be first done between 9 to 12 months of age if you could do it. In my department, we probably do it only the first time when the patient is about 3 years of age and at least 5 times more between infancy to 20 years. And maybe even more if the patient has the following: different UTI, high residual urine, or new onset Hydroureteronephrosis. Mind, when I say 20 years, my commitment is to see this patient of PUV till I live. Or if you are not in service or you retire, must pass on to a competent pediatric surgeon or pediatric urologist friend of yours. So what are the different urodynamic patterns? They could be normal, they could be uninhibited contractions, high body pressures. But the two different urodynamic patterns that are usually seen are small capacity bladder and neogenic failure. 2 slides on this. If you would see till 90 ml of bladder filling, the pressures are rather low, but at 250 ml, which is less than the expected bladder capacity of 350 ml in this patient, suddenly the pressures rise and the patient leaks. So we know that we probably need to tell this patient to do time voiding. So before he fills up to 250 ml, he needs to go and pass the urine so that the blood pressures are not that high to hamper the kidneys above. This is another one. If you would see all through, there are small little contractions more than 15 ml centimeter of water all through, which are uninhibited contractions, and suddenly in this expected bladder capacity 175 ml, 75 ml, this patient suddenly produces pressures rise. So you know that this patient probably needs sediment. Bladder dysfunction is another area which for the last 10-15 years people have been talking about, that even after doing valve ablation or EVI, as I said, patient have bladder neck hypertrophy and which does not work as well in coordination with the bladder. That may be a problem. So surgical or pharmacological intervention needs to be done to improve this bladder neck obstruction. This is my own pictures, BNI. We have published a paper in PSI in 2013. We did a small pilot study. This is how BNI is done. You can do the same while doing valve ablation. A cut is given at 6 o'clock position. Lot many people ask me, because it's not written in literature very well, how would you know how much to cut, how deep, how down do you go? So we all know when the bladder neck is hypertrophy, when you're doing a scopy, you need to really literally look towards the sky before you enter into the bladder. So you give a cut enough so that you could go into the bladder straight into it. I mean, that's the easiest way I can explain how much to go. Surely you will not come right up to the veru. We'll stop before the veru. And BNI, although did not produce great results in our pilot study, but I'm still continuing with the study. I will come with bigger cohort results soon. Treatment strategies for valve bladder syndrome: urotherapy, CIC, drug treatment, botulinum. We have done a study in our department where we have used to inject botulinum toxins in the bladders which are not responsive to the usual anticholinergics. After failure of anticholinergics over 1 year, we will go on to doing Botox injections. A new therapies like neuromodulation are known, anticholinergic drugs, oxybutynin and tolterodine, and we have been using for long time. But the new drugs on the block also includes miraviron, which is now being used in children as well, and we have an ongoing study on this as well. I must emphasize on this slide where CIC and night drainage has to be done. If the patient has got high PVRV, in spite of your valve being adequately incised, and you need to do CIC on this patient and also give this patient a blood drainage. This needs a lot of counseling because CIC and the night drainage is not very easily accepted by low socioeconomic group patients that are coming to us in our public hospitals in majority of the part of the India, at least in the north and central India. This is a slide on neuromodulation. So there are different types of neuromodulation also known, and people have tried this and they've worked on unresponsive bladders. Yes, you may have done an adequate PEVI, but still these patients may not have having UTIs, and although the ongoing treatment of bladder therapy is going on, but still these patients may need some secondary surgery. So these surgeries could be in the form of primary or secondary diversions. Primary diversion I've already talked about. Secondary diversion after doing adequate EVI. And some patients will need reflux management and mitophilon may be required if these patients need CIC, and many patients also may need augmentation. The last but not the least is the renal transplant in patients in adolescents who go into end-stage renal disease. So this is not my data, it's the data from Dr. Sudipta Sen, who says that at least 35% of their patients had secondary diversions which needed undiversion later. But all these diversions, secondary diversions, I mean, they kill your social life, so they should be done as early as possible, and undiversion ideally should be done before 3 to 5 years of age. The renal transplants, 30% of the survivors need transplant in the long run. I'm a very, very emotional, sensitive person. Maybe many Punjabis are. And trust me, I've been to the funerals of my patients whom I have treated for about 20 years, and the patients eventually never got renal transplantation because of many reasons and died. And I went and I cried and howled in these funerals. So I'm one person who's been trying my best to start a pediatric renal transplant program in a public hospital which will be freely available to everybody. Renal transplant are being done in cities like Delhi, but far and few. Only about 4 or 5 pediatric patients undergo renal transplant in a city as big as Delhi, where there is a large referral So we need to create such facilities within our departments. And majority of the renal transplants under the pediatric age are because of obstructive uropathy, and PUE also stands out with that. So prognostic factors, if the patient is being under treatment, the parents ask you, and you need to know yourself these are the prognostic factors that are known in the literature. Adverse prognostic factor is the prenatal diagnosis less than 24 weeks, poor urinalysis on bladder function report, nadir creatinine at 1 year of age of more than 1 milligram percent is bad, bilateral VUR is severe QM, which does not improve with time, is bad seen. And diurnal incontinence and proteinuria beyond 5 years of age, these are patients who eventually may go into end-stage renal disease. Hypertension and presentation could also cause problems. The favorables are the one creatinine less than 1%, absence of EUR within rectal, preservation of the CMD of the kidneys by renal ultrasound, and radiological evidence of a pop-up valve like urinary cyclase, VUR syndrome, and large bladder diverticulum. A recent article published in General Pediatric Urology is actually questioned whether these pop-off mechanisms are really good for these kidneys, and they believe that we're actually fooling ourselves. I conclude with this slide that primary endoscopic valve incision that I call PPAV alone may suffice in about 30% of the patients. Diversion and undiversions may be required in few, primary or secondary, but majority of them may need, 40% may need a second operation, 10% will need a bladder augmentation, 20 to 30% will need the renal transplant. So never forget the sequelae and need for long-term follow-up. A pediatric nephrologist in the part of the team is a blessing. So if we could have a clinic where both the nephrologist, pediatric nephrologist, and pediatric urologist sitting together, that's fantastic. Cystometry should be performed in all patients of PUV. But if you do not have the UDS machine, no problem. We have also done a study on bedside cystometry, which gives almost the same kind of information as a cystometry study on a UDS machine. And bladder dysfunction in boys with PUV changes during childhood and through adolescence, and that is the time when bladder failure will occur. So you need to know then when to stop your anticholinergics, how to kind of ration or adjust dose of your anticholinergics, and how to take them through the adulthood. And I repeat my words again that you should treat these patients, keep them under follow-up as long as you live, or if you retire, pass it on to a worthy colleague of yours. Thank you so much.
Thank you very much, Dr. Yogesh, for your very